Any amendments to the agenda this morning?
Mr. Chair, Dr. Arrows here. If we can add an item under 10 other COVID mitigation measures for special events.
Any amendments to the agenda this morning?
Such as Halloween and Christmas. It was requested after the agenda went out.
Okay.
Mr. Chair, it's O'Leary. I'm wondering under number 10, other, we could have a discussion on the Municipal Drug Strategy Coordinators Network of Ontario. I think that that might have been correspondence from the last meeting that I was unable to attend, but I did want to discuss it if you would allow.
That's fine with me. Does any of the other board members have concerns with that?
Sorry, it's Erin. I believe that will be maybe included in the staff presentation.
That's a good call. Mr. Chair, through you, the presentation from staff under number 6 is mitigation strategies for overdose prevention during COVID, and it's presentation by one of our managers.
Yeah, because there is a couple of endorsements there. So Brian, is that something over and above these two items under 6.1 and 6.2?
Well, it is really. It's kind of a separate issue that I'd like to discuss, and I would prefer to do it under other business if that's okay.
That's fine with me. Is that okay, everyone? Okay, so are there any other amendments this morning? Do I have a mover and seconder to approve the amendments to the agenda?
Sue, I'll move it.
Moved by Sue.
O'Leary.
Brian here. I'll second.
All right. Is anyone opposed? Hearing none, I will consider that carried. Approval of the agenda this morning. Do I have a mover and seconder to move the approval?
Edie. Buck here. Oh, I can second it, Buck.
Okay, Edie and Buck. Anyone opposed to the approval of the agenda this morning? Hearing none, I will consider that approved. At this time, I'd ask anybody to disclose pecuniary interest, either now if it arises down the agenda. Seeing or hearing none, adoption of the minutes from Friday, August the 28th. Do I have a mover and seconder?
Milne, I will move.
Millen,
Sue, I'll second.
Patterson, second. Anyone opposed to, or sorry, is there any omissions or discussions from those minutes? Hearing none, is anyone opposed to the approval of the, or sorry, the adoption of the minutes from August the 28th? Hearing none, I will consider those approved. Thank you. Okay, staff presentations this morning, mitigation strategies for overdose prevention during COVID-19. Ian, are you in the building?
I am in the building. Thank you very much for this audience this morning. Really happy to be able to discuss this challenging topic. So I will just share my screen right now to pull up the presentation. So just bear with me 1 second. Oh, I have a privacy setting that I'm not able to share my screen while others are sharing theirs. So it looks like maybe we have to stop sharing the board agenda and allow me to share the presentation, if that's possible.
It's done, Ian, you can proceed.
So yeah, I'm still not able to share. There we go.
There you go.
How does that look?
Good.
It's not in full screen though, is it?
Not yet.
There we go. Perfect. So again, thank you very much for allowing me to just discuss our intervention strategies that we have adopted or implemented during.
Sorry, Ian, it's not in full screen yet. I wonder if you can unshare, make it full screen, then share the full screen. Zoom chooses one of the two, usually not both. Thank you.
It does not seem to be allowing me to do that.
So I think the board, could you see the screen that Ian did have up? Because I could see it and read. Is that okay with the rest of the board? Yeah, so what you had before Ian's fine.
Okay.
There you go.
That look okay? All right.
That's
Thank
good.
you for your patience, everyone.
It's full screen, actually. Good.
All right. So again, thank you very much for allowing me to talk about this. I just wanted to share some of our mitigation strategies that we have implemented in the face of COVID, because it has been a very challenging time to make sure that we focus not only on COVID, but also on the other public health crisis that is ongoing and that we have felt fairly strongly here in Grey and Bruce counties throughout this past summer. So I'll just go through quickly. This is a list of some of the response strategies that we have implemented in response to the overdoses that have happened. Obviously, our overdose alerts that went out in late July relating to the rash of overdoses, as well as the fatalities due to overdose that we experienced during that 10-day period. Also, I do want to share information about our awareness campaign for the overdose prevention line, which ties very nicely into COVID-19 and the challenges of the dual message of having to try to isolate while we were early on in COVID, at the same time of trying to ensure that people that use drugs use in groups. So I'll talk a little bit about that, as well as I'll just share that we were successful in onboarding Hanover Hospital in the expanded naloxone program. So I'll discuss that a little bit, as well as update on a new harm reduction site that we are testing in Wyerton to see the uptake and the potential for spread and sustainability of that moving forward, as well as a new program that we're partnering with Grey and Bruce County Housing to provide outreach services to those housing facilities that are experiencing challenges with overdose or drug use in their housing projects, as well as some harm reduction outreach that we have done, and a brand new program that the ministry announced late summer that we have just initiated, which is some expanded access to naloxone. Really excited about that. So just to cover off our media releases that we did provide regarding overdoses. Our first media release was in relation to a cluster of overdoses that happened in and around the date of July 21st. There were, over the past 5 days, over 5 overdoses that had happened. And through anecdotal evidence, we were made aware that one of those overdoses was fatal. It followed up 10 days later, unfortunately, by another alert due to a rash of 3 fatal overdoses in a very short period of time that were not only centered here in Owen Sound, but also in smaller communities throughout Grey and Bruce County. Just to tie in some provincial numbers as well for context, you can see that the number of deaths related to opioid overdoses continues to rise throughout the province. But I think one of the most striking numbers is in the next slide when you look at Grey and Bruce. Unfortunately, 2019 did see the largest number of fatal overdoses that we have ever seen in Grey and Bruce counties since we have been recording them at 18 deaths that did occur in 2019. Preliminary numbers for this year shows us being on pretty much the same pathway. We do know of confirmed 4 fatalities in the beginning of the year of 2020. That's confirmed by the coroner's office. However, we do also have anecdotal evidence, needs to be confirmed by the coroner's office, that we have 10 fatalities since COVID has started here in Grey and Bruce County as well. So one of the biggest struggles, I think, during COVID was our messaging about the importance of staying away from others, the importance of making sure that personal distancing is practiced. The challenge with people that do use drugs in our harm reduction circles is the most important message we have for people is, if using, please use together, don't use alone. So because of that challenging message, this wonderful program out of Hamilton, actually, you may remember Rebecca, who presented at some of our town halls last year. She has started a program out of Hamilton that allows people to call in to this number if they are going to be using and they are alone. The caller will then be able to stay on the line with that person while they use. And if they become unresponsive or do not answer the phone, they are able to call 911 from their office down in Hamilton to ensure that emergency responders can respond to that fatal potentially fatal overdose to prevent it from turning fatal. So we really did a lot of outreach. We shared this with as many community partners as possible. We printed it on the back of our overdose awareness cards that we hand out to our EMS partners, police partners. We also handed it out during many of our outreach visits to the downtown core here in Sound as well. Happy to announce also we finalized training with Hanover District Hospital. So they're going to be able to dispense naloxone directly from their ER for the family, friends, but also the clients that do leave the ER if they have suffered an overdose or a near overdose. So this is another just strategy to ensure that once people leave a hospital, if they do choose to go and use again, they have that naloxone on hand in the event of a further overdose. We've also developed a test site in Wyerton. This is in partnership with CMHA. They have provided free space for us in Wyerton to provide needle exchange and naloxone distribution twice a month on Thursdays. And what this initiative really is for is because there's very limited access to this type of supplies up on the peninsula. So this is our first test to see if there is buy-in and if there is uptake. And if there is, we want to look at spreading this and seeing how sustainable it would be in the future. We've also done a lot of community outreach. This is really involving education, awareness, as well as distribution of harm reduction supplies to those that do require it or do share an interest. So we have done some outreach in partnership with counselors at New Directions in Hanover. We've engaged with apartment buildings and individual houses directly in Hanover to ensure that they have access to not just harm reduction supplies, but are aware of mental health and addiction services available to them. We also have done lots of outreach in the Lucknow area, as well as in the Owen Sound area. That has been in partnership with CMHA, British Health Unit staff, as well as at times police agencies will come along with us, not in uniform, but more in a community service sort of way. And the uptake has been very positive. Obviously some challenges, but that is more pertaining to the readiness of the individuals we are interacting with, as opposed to their want or will to have us there. We're always very welcome every place that we do go. I did mention we are working with Grey and Bruce County Housing. And what we want to do is provide them a simple way to connect with us if they are concerned or feel a need for us to do some harm reduction outreach within any of their housing areas. As well as obviously working with CMHA, Hope Grey Bruce to expand our partnership to consistently provide a wide range of outreach services, as opposed to each of us doing things individually. We're really trying to coordinate that to make sure that we can do it all together at the same time. One of the most exciting pieces of news that I received this late summer was the ability for us to onboard agencies that were historically not eligible to dispense naloxone throughout the community. In particular, family health teams, police services, and EMS services. We've been successful at onboarding Owen Sound Family Health Team, as well as the Family Health Corporation in Wyerton, to be able to dispense naloxone directly from the physician's offices. So as a client comes in and is talking about their substance use issues or challenges and admits to the physician, you know what, I am still using, that physician now is empowered to open their desk and provide that client a kit along with the training for overdose prevention. We are working very closely with our EMS providers as well to see if we can get them the ability to dispense naloxone in addition to providing life-saving services to leave naloxone kits at those places that they have picked folks up on from to leave naloxone kits to those users that will still more than likely be using later on that evening or the next day or so. So EMS is investigating that ability and we look forward to being able to submit any sort of application once they are ready to do that as well. And that brings us to the open call from the Municipal Drug Strategy Coordinators Network of Ontario. They did send some letters to both the federal government as well as the provincial government, trying to endorse the idea of providing or having the ability to coordinate and provide a safe supply strategy within the province of Ontario. You will know recently there's been 4 sites within Ontario approved to provide safe supplies. So we're really looking forward to finding out their successes and challenges from their programs But next, really, it's wanting to develop a working group at the opioid working group level to really look at the literature and look at this as a potential strategy for our location moving forward. And just to provide some context as to why this came about, 73% of the fatalities to date due to drug overdoses here in Grey and Bruce counties were a direct result of their drug supply containing fentanyl or carfentanil. So 3/4 of the people that have passed away was not because of their addiction or their opioid use. It was because the drugs they were taking were tainted with a deadly product. So safe supply is one single strategy, and I'm cautious about that. It's only a strategy that's used to help prevent that 73% of people from passing away. And it's not the golden ticket. It's not the sole answer, but it is a very important piece of the puzzle that I feel is needed to be able to move our initiatives forward. You'll notice that our death rate has not declined. All the strategies that we are implementing, the naloxone, the safe needle supplies, all of those strategies, as effective as they are in real time at preventing a death, we haven't seen a decrease in the number of people that are dying. And I do believe that the safe supply, through the literature that I've read and the programs that I have assessed, a safe supply is one step in the right direction. Along with, I have to admit, we really need to offer real-time mental health and addiction services for those folks when they are interested and when they are ready. So that's another big piece that I think goes along quite well with the safe supply. So I know I provided the letters, and you're free to review those. Really, I think a big ask is if the Board of Health would endorse the letters as are, to give me more support or feeling of support to move this initiative forward with the opioid working group. I want to be very cautious that I have the support of the Board of Health before moving forward on anything like this. So I really thank you again for the time here. But I do want to also cover off a couple other things, and I'll take some questions at the end if there is some time as well. So I did just cover this letter here. But next steps, I just want to let everyone know that this is what we've done in the face of a pandemic, in the face of some challenges of making sure that our staff can stay dedicated to this work. And I have to say a big shout out to the harm reduction team for working in this conflicting environment, conflicting priorities. They really have done an amazing work under the circumstances to make sure that this is at the forefront of what they do. So obviously we will continue to work within our program and in conjunction with our system partners to enhance harm reduction practices. We'll work within the opioid working group. I'm really excited to have a new health promoter on from Chatham-Kent, was her previous job, and she has experience with harm reduction. So we're working on a wholesome prevention plan that outlines how do we prevent use of drugs to begin with, but then also how do we prevent harms associated with those drugs. So I'm really looking forward to our presentation in October to the opioid working group that will highlight that strategy and look for adoption from the opioid working group to move that forward. We are really excited on our engagement work with people that do use drugs. We take a lot of their feedback to heart, and we do implement the suggestions that they do provide to us through the harm reduction program as well. Also, we are excited to just begin the investigation, but moving forward to design and implementation of a very focused Indigenous strategy in regards to opioid use and drug use in general. So very much looking forward to that strategy as well, just to give you a snapshot of the work that we have in front of us as well. So that is the end of my presentation itself, but I will definitely look forward to any questions that we may have. I'm just trying to find the stop share button. There we go. So open to any questions if there's time. Mitch, I think you're on mute. I see you talking.
You're right, I was just saying to myself here, I want to thank you, Ian, and if you can pass on our gratitude to the team on behalf of the board and our citizens. I know this this issue facing not you know, every one of our communities are impacted with this. So I just want to say thank you to you and the group, and if you could pass that on, that'd be great. So I will open it up to questions for Ian right now.
Hi, Ann.
Hello?
I wanted to ask a question, but I thought I heard somebody else's voice.
Oh, I just said hi, Ann.
Oh,
I saw you with your hand up.
oh, okay, sorry. So I'm interested, can you just explain the safe supply as better? Like,
For
what
sure.
is the range of drugs you're referring to, and how can it be safer for the ones that, for the users?
So I was very cautious saying that safe supply is one single strategy. And the reason I say that is a safe supply is what it can be provided through direct medical or healthcare professional interaction and provision of pharmaceutical grade opioids. It could be medical grade heroin, it could be dilaudid, it could be a fairly strong heroin analog or relation to heroin, but it's done directly in conjunction with a healthcare provider with access to mental health and addiction services. So really, this is a strategy used to stop someone from using the toxic street drug supply, while at the same point in time having constant interaction on a regular basis with healthcare professionals in anticipation for that time when that person is ready to make a shift in their journey on recovery. The move to going to a safe supply takes a lot of work and energy from someone that is using drugs. So it's not the silver bullet, because that person will need to be motivated to take that first step to access these services. However, once that access is made and the safe supply is in place, the person then has a whole suite of services available to them when they are ready to move along their journey of recovery. So we're taking away the toxic supply of drugs from those that are ready, understanding that the fatality rate significantly decreases, if not is non-existent. Again, that's why I'm waiting to see the stats from the Ontario projects. But once that is taken care of and we open the doors up to those other services, our hope is, and the literature does support it, that they will continue on their journey of recovery. They will develop that sense of community, that sense of belonging, and that sense that, you know, they're not feeling stigmatized, they're actually being welcomed into this program. So again, it's a step and it's a piece of the puzzle, and it goes along with so many more things. I do have a long video, and I wish I could share it, but I urge anyone that doesn't know Gabor Mate to look up his videos about addiction and his work that he does on the east side of Vancouver. Because really, addiction starts generally, not always, but generally, with some sort of trauma. And Gabor Mate speaks to it so eloquently and describes childhood trauma as every traumatic event that a child experiences adds exponentially to their potential risk of developing an addiction challenge later on in life. 8 events add up to a 3,600% increase in chances of someone struggling with an addiction issue. So every traumatic event that a child experiences adds to the likelihood of addiction. So that really ties in the evidence that addiction really ties so much into trauma and mental health, and how we can ensure that we treat those that are growing in life to prevent, when they get to adulthood, prevent the need or the want to move towards drug use. So long-winded answer, but I hope that provides some clarification about what a safe supply is. It's a supply under the direction of medical professionals. It's not just a going on the streets and handing out drugs. This is done in more of a clinical type setting, similar to a safe consumption site without the consumption, just the distribution of the medications.
Thank you.
You're welcome.
Oh, that's great to know.
Any other questions or comments for Ian?
Mr. Chairman, if I might.
Yes, sir.
You know, it's very interesting, given the comment about childhood trauma, one might think that the response would be more input, more intervention, more participation in childhood mental health, because we know that that's where it's coming from. And if we know that that's the source, then why wait until they become adult and get into addiction? Should we not be putting and advocating more for childhood mental health?
Absolutely. you know, I 100% support it. I think the harm reduction strategies that we have in place are there because of what's happening. People are dying, right? We want to make sure that all the tools are there to save those ones that are currently stuck in that place of substance use and addiction. But wholeheartedly agree. I think there needs to be a huge shift in not just design, but also funding for childhood mental health, identification, treatment, as well. And it ties also into our foster parenting and whatnot. So it's such an interconnected challenge that I think we're reaching a point that we understand harm reduction works to help people save their lives now, but to truly see a difference leading into the future, we need to address the issues in childhood as we see them right now. It's been really big in the media, but something as simple, not as simple, but as traumatic as children that see their father shot by police officers or shot by criminals. It doesn't matter what it is, but seeing or being in that traumatic event, the child may not share, may not vocalize their concerns, but it's definitely up there. And that's why a lot of times you don't see this until someone becomes an adult. They repress that memory. They don't want to remember that memory. But as they grow, they start remembering, and the trauma comes in waves, and it comes very, very strong. And that need or that want to numb that pain is so big. So wholeheartedly agree. I think a complete system redesign for mental health for our children is definitely something that I would love to see.
Through you, Mr. Chair, Dr. Eras here, that is the key variable to tackle the prevention, not just the harm reduction. Harm reduction, as Ian mentioned, is to help people who are stuck in the situation at this point, but from a societal point of view, to actually put a positive dent or prevent this issue is the early childhood. And in the health unit, we have Healthy Baby, Healthy Children, and we tailor our interventions for high-risk families specifically to help with prevention as early as we can. To my delight, I've seen in the system in the past 5 to 10 years more awareness from partners around the table, whether it's the police, first responders, or any other partner, to realize that the issue that they're tackling in the legal system or in the enforcement sector of a part of the system is really related to a childhood development. And there has been shift in the discussion from focusing on the end result rather than the start. And again, this is something that's not going to change in 2 years or 3 years. This is truly the public health work that's going to come in the coming 20 years, 30 years, similar to what we did with tobacco. Tobacco at some point was normalized for people to smoke in a hospital. Now, most kids, most of the new millennials would not even think of a possibility of smoke in a hospital or in a public place. But that's really the core of the issue, the childhood development.
Okay, any other questions or comments? There are 2 letters there for endorsement. Do I have a mover and seconder to move those?
Edie?
Ann?
O'Leary.
O'Leary? Is there any further discussions on the endorsement of those letters? Hearing none. Anyone opposed to supporting the letters? Hearing none, I will consider that carried. Thank you. Okay, moving on to correspondence and news releases.
Thanks, everyone.
Thanks, Ian.
So this is Dr. Era here, through you, Mr. Chair. We have 3 correspondence. The first 2 are for receipt. The third one is for endorsement. And it's worth mentioning the third one is to endorse the Royal Society of Canada working group to optimize or improve the delivery of care and the prevention of transmission of infectious disease in long-term care. And the communication comes from Simcoe Muskoka, and it's highly recommended to be endorsed if the board sees so.
Thank you, Ian. There's Dr. Harris, sorry. The first 2 are for receiving, and the third one is for endorsement. Do I have a mover and seconder to endorse?
O'Leary will move it.
Thanks, Brian.
Patterson, second.
Patterson is seconding it. Is there any discussions on that item? Anyone opposed? Hearing none, I will consider that carried. Thank you. News releases, Drew.
Sorry, that's under the same, sorry, it's under, this is Dr. Era, under the same item, correspondence and news releases. And if there are any questions about them, we list them in the interest of time. If there is any question, we will discuss.
Just one question under the Little River Park Beach. Do we have an idea where the source of E. coli is coming from?
Say that again, Mr. Chair. Sorry, the line was choppy.
Sorry, the Little River Park Beach. I was just wondering, do we have a source of where that E. coli high levels are coming from, or is it just a snapshot?
It could be from many sources. E. coli usually exists in human feces or animal feces. It can exist in nature. If there is periods of rain that could increase the flow or the levels in the water, the different environmental factors, whether it's warm weather or rain, can change this. This is not uncommon. We continue to monitor and see if there are any significance to it in the emergency department or in schools, absenteeism or similar indicators that we follow.
Okay, thank you. Any other questions or comments on the news releases? Okay, thank you. Moving on.
So the next item is with myself, update from the Medical Officer of Health, and Aaron is gonna put the slides on the screen momentarily. So if we can move to the next slide, Aaron, please. So the objective is threefold: to look at the update from the school, examples from the surveillance tools that we have, and the third one is the challenges that we have been facing in the past 2-3 weeks and the potential solutions. If we can move to the next one, please. So the surveillance, one of the surveillance systems is for absenteeism from schools, and this is just the definition of the data that goes into it. It comes from 2 board districts, the Catholic and the Blue Water District, and we collect this information on daily basis. It comes in at 5 p.m. every day. We view it in the next morning, and we act on behalf, act based on the findings of the surveillance system in many ways that I will mention in the next slide. So those are the symptoms that the emergency department would report on, and we also pick up signals from this system, and you can see it's a wide array of symptoms similar to most viruses that are from the same COVID family or similar families. They overlap, whether it's runny nose or cough. There is no way to identify one or the other from this system. However, whenever we see a signal going up in emerge, we can calibrate and tailor our interventions in schools accordingly. Next slide, please. So this is a snapshot from the dashboard that we look at, and it would show number of schools, and any school that has over 10% absenteeism will be flagged. And the absenteeism, the data is not specific for symptoms. So a person could be, or a kid could be absent for many other reasons. This is not the tool that we would go and act specifically as if there's an outbreak. However, it provides an early signal of what's going on. And if you can go to the next slide, please. On September 17th, for example, there are couple schools. This is the average of all schools, but we will see each school specifically. We actually contacted the school before they contacted us, and we It was rightly so that the principal was aware and wondering what they need to do and who they need to call. And we actually called them beforehand based on this data. If we go to the next slide, this is the same view just from different days. So this is September 18th, and you can see the absenteeism rate went down after the first intervention. We estimate that would be the letter for the anxiety from parents. And if we go to the next one, then picks up again, and the next one, please. And we continue to see this. Currently, there is high absenteeism rate in schools. And when we look at it, we're exploring with the schools, our public health nurses exploring with the school officials to see, to take a sample from schools and see why the absenteeism rate is. We know it is not illness in all kids. So is it anxiety that many kids went absent in some class and the rest of them or the rest of the family had the anxiety that there could be a case? And we've seen this couple of times in the past 2 weeks where there was a rumor that there was a case in a school and there wasn't. And again, we would have just to tackle those, as I would mention in the next slides, as we go later in slides about risk communication. So this is the other tool that we use, emergency department visits. And you would see during the summer, there is a plateau. Around that time, the start of the school or and 2 weeks after school reopening, we saw that surge. And again, you can see it on two systems, which makes it real. And when we explored it more, we found there are two reasons for these spikes. If we go to the next slide, please. I will touch base on this item, then I'll go back to this slide should have, it's probably, if we can go to the next slide, please. Sorry, Aaron, if you can go back to the previous slide. So I'm just going to switch gears from the absenteeism, and I'll address it at the very end of the slides. There are a few other challenges in the schools. We receive complaints from teachers or from staff, some staff, not everybody, that there is shortage in schools, and we work by definition with the school officials at all times. And the actual picture is most schools have optimal supply. There are a small number of schools that there is shortage, and it has been mitigated in different ways. Mainly the Ministry of Education has supply. However, the timeliness of it has created this shortage. So there is PPE and hand sanitizer in the system, however, didn't reach these schools. Bruce Power has donated PPEs and hand sanitizers to many schools, and my understanding from communication with Bruce Power executive, there is an initiative to top up all schools again for a period of time. Gray County EMS has generously provided the surplus or part of the surplus that they have, and we are in the process of helping distribution of these resources to the schools that need the PPE. I don't think this is an issue that's going to persist, and it should be addressed within a week or two from now based on the three sources that we have. Next slide, please. So the main challenge that we have seen is the testing capacity, whether it's in the assessment centers and the lab. The final point, or the second part of the slide, is about the lab capacity. So the lab has moved to pooling, and pooling, forgive me if I get technical, every lab has robots that run the test. It's not humans, it's all automated. And these little robots would take a test and or a sample and test it for COVID. If pooling is utilized, the robot will take 3 or 4 samples and test them. And if all of them came back negative, that saved 75% of the time, or fourfold increase in efficiency. If it comes back positive, the 4 samples will be split and tested separately. And because of the odds, the 4 tests are going to be negative. pooling would increase the capacity in orders of magnitude immediately. So the lab currently has a capacity of 40,000 per day, and we're getting most of the results within 1 or 2 days, which is optimal. Currently, this is a question that many people ask about the saliva test. It is approved in Ontario. However, it's approved for research and specific indications for certain conditions in children. And many people think that, collecting a saliva sample might be easier than the nasal swab. According to pediatricians that I spoke with, it's not very easy to collect that amount of saliva from a little kid. It could be very difficult process, as similar as a nasal swab. So if we go to the upper part of that slide, which is basically the demand and the supply for testing. Symptomatic and exposed are the only people who should be tested according to science and the recommendation. And yesterday, the Chief MOH's office and the provincial announcement included that there's going to be shift in narrative to focus on people who need it. And those are the people who need it. Asymptomatic people, whether it's anxiety-driven, mass testing, long-term care staff, or long-term visitors, there is evidence, mounting evidence, not mounting evidence. It's basic science that people should not be tested without symptoms. However, during this summer, because there has been testing and strategies to test asymptomatic, there has been evidence that accumulated through Public Health Ontario and other bodies that shows that it's not adding benefit to the management of the outbreak, and it's potentially causing harm. If we can go to the next slide, please, Aaron. These 2 paragraphs are from a letter of advocacy or advice from the COMO, Council of Medical Officers of Health, wrote a letter to the Minister of Health, Minister of Long-Term Care, CC'd the Premier, and those paragraphs came in that letter. The first paragraph is in the letter itself. The second paragraph comes from the 6-page report that's attached to that letter. And you can see from the second one, each false positive in a long-term care would cost the system, societal view, around $100,000, because people are going to be locked in with using PPEs for 5-6 days. The number of staff who are working over hours, the response from public health, and the contact tracing that would, just to prove it's false positive. And can you see in the first one, the last line in the first paragraph is almost certain to do more harm than good. And again, there is change in narrative, and hopefully the media would augment this and the public would get the right information so they can make decisions that will help them, truly help them, not just provide false reassurance, and will help the system to maintain capacity to respond to the emergency. If we can go to the next slide, please. Again, this slide just to emphasize the people who need to be tested are symptoms and exposure. And the exposure should be defined by public health. We call these people, we say you're exposed. It's not just a person sitting, a kid sitting in a class where there was a case, or in a school that there was a case. If we go to the next slide, please. So this is where that surveillance system I spoke about early in the presentation picked up a couple signals. So as we all know, in the past 10 days, there has been, or 7 days or so, surge in the number of people attending assessment centers. So to the best of our assessment, there has been 2 distinct reasons. The first one is easier to tackle, which is the heightened anxiety, worried individuals, whether parents or individuals who tested themselves or requested tests for themselves, not related to schools. And that's mainly because there is raise in the numbers in the province. We sent a couple communications. One of them is the letter to the parents. So this communication would probably take care or mitigate this risk. There was another reason why this risk was mitigated, which is the second risk, the significant issue that raised the number of people attending assessment centers, which would make it difficult for any person who want to test based on anxiety to go to the assessment center. So one of the 2 issues actually mitigated the other one a bit. The second one is the assessment tool for screening in schools, it's a provincial tool, and it's based on science, and it's endorsed by medical officer of health. The tool itself is no issue. The use of it has been an issue. So it's understandable, parents or people who are using this tool, whether in schools or other, they're not a healthcare provider. So to them, one symptom is one symptom. For example, headache or cramps for half an hour is a symptom. To a healthcare provider, or if the tool needs to be used properly, cramps need to exist for 6 hours, 5 hours, or the headache should not be just half an hour. So to mitigate this, the province put together an electronic tool with an algorithm embedded in it to assess these symptoms a bit further. And that was implemented Monday this week in Grey and Bruce. We have seen from the assessment center feedback that this is working, because all the kids who are being sent recently from Monday till now have actually symptoms. Runny nose is the major one of them, 80%, and I will touch base on that. However, the surge or the capacity of the assessment center has still been challenged during this week because of the kids who were sent last week, and because of the other people who wanted to be tested as well. So we anticipate this will be flattened, and it's worth mentioning this is across the province. This is not just Grey and Bruce. The runny nose issue, you probably heard it from many parents concerned. It's about 80%, as I mentioned, of kids who go to the assessment center have only runny nose. And there is always the question, like, is runny nose not normal? It is normal sometimes, and it could be COVID in other times. The data that came out yesterday from Ottawa Public Health says of the kids who had COVID, diagnosed COVID, 17%, that's around 1 in 5, has only runny nose. Only runny nose. So again, the tool pointing out that runny nose is a risk for COVID is appropriate. And if we need to ensure safe reopening, we need to consider these things. It's worth mentioning that we started with a stringent and conservative approach, and the goal is to loosen that restrictions as we go. So we would anticipate from the province to go from 1 symptom at the threshold to send kids home to 2 symptoms. The last communication 2 days ago with the province, they're not ready for this yet. In Grey Bruce, we are ready. However, it's just the changing gears before the province in certain things is not the optimal way to do things. We have right now 2 weeks worth of testing and data, and all of it is negative, which is reassuring. And that allowed us to move from self-isolation of all family members to a kid who is symptomatic to self-monitoring. So 2 weeks ago, if there is a kid who has symptoms, the whole family will self-isolate until the test comes back negative. Currently, they can go back to school and to work until and only the kid would be self-isolating. So this is, for example, a change that we moved before the province, but just because I know the next guideline is going to be carrying the same recommendation, whether next week or the week after. And because we have the epidemiology favorable in Grey Bruce, and we have the data that we accumulated in the past 2 weeks. So if you asked me 2 weeks ago, would you do this? I would say I'm not with highest level of certainty that this is safe, because we didn't have the data. Today we do have the data, and this is something that's going to change as we go. If we go to the next slide, please. So this is currently the main guideline. If there is a kid in school who has symptoms, they need to be either tested or isolating for 14 days. The rest of the family doesn't have to isolate. And we will be introducing more support to the school staff to make these assessments. So if If the symptom is very clear, somebody's coughing and there is runny nose and there is fever, that's an easy decision. The school, based on the assessment, the screening tool can send them home. If a kid is in a gray area, our nurses will help in making these decisions. And again, the different levels of the system, whether it's the assessment center, the school, public health, are collaborating. And you mentioned or commented earlier in the meeting, or before the meeting, it is a process that nobody has initiated. The last pandemic of this caliber was 102 years ago. None of us have gone through this before. And we know that our protocols in public health are robust. We deal with this as bread and butter because it's very similar to the flu, very similar to salmonella, and we practice and exercise pandemic planning and response on annual basis. However, collaboration with different parts of the system and their knowledge of their roles in the middle of this, one is not as robust until we work on it, and two, it is going to be changing. Currently, for example, primary care does not do much testing. In the near future, we might see them testing. The pharmacies might come on board in part of the province. So all these things are new partners, new variables in the equation. If we can go to the next slide, please. So as I mentioned, all asymptomatic people without symptoms in a household can self-monitor, go back to normal life. I feel very comfortable that we are at a level we can allow this. For a symptomatic individual without negative test, they need to isolate for 14 days. This is, again, you might hear it from the public or from parents, from different individuals who are concerned. Why not going back? There are no symptoms. We know that COVID, an individual infected with COVID can be shedding the virus for 14 days. So if we don't have a negative test, we cannot really feel that it's appropriate for that person to go to a high risk setting like school. The final point there is, if a person tests negative to COVID and they still have runny nose, why can't they go back to school? And truly, there is no risk of COVID transmission here. However, that kid, if they're back in the school or kindergarten and they infected 4 other kids with common cold, we need to treat these 4 kids as COVID until proven otherwise. So they have to be tested, they have to be isolating, and there is more anxiety. So for the sake of sending 1 kid back to school, we're going to be potentially sending 4 kids out of school. And that's why we stand behind the 24-hour symptom-free as an important factor, whether there's COVID or not. If we can go to the next slide, please. And we're closing to the end of this presentation. Communication framework. This is one of the tools that we use in seeing where the public is based on the input that we receive. And you can see on the x-axis, it's the hazard, the real risk, and on the y is the anxiety or the outrage or the concern that's associated with it. And these things could be congruent, could be not. If you go to the upper right side of the graph, there is crisis communication. So this is if there is multiple outbreaks in this example in schools, and there is real hazard, real risk, and parents are, or people, staff are outraged, they're concerned. The communication that we would have would be the last one in the slide, that last item, crisis communication, to actually give information to the public and to let them know what they need to do to take care of the situation that's hazardous. The one under it, the green one, precautionary advocacy. When there is real risk, but people are not concerned, they're not aware of it. And you would see this in this emergency, not during these days. Most people are very concerned about it, but you would still see, if you're looking at smaller community or a smaller facility where there is not enough understanding of the risk. And you would find it, for example, in younger people who think they're immune and to the disease. There are no high-risk complications that would happen, and that's true. However, they're missing or some of them, I do believe, if they know the fact that they are part of a chain of transmission. So they're not going to be affected. The next person they're going to infect is young, and they're not going to be affected. But the third person is an older person is going to suffer. This knowledge, if it's provided to them, we can move that green circle to the blue circle, to the happy medium. So a person would know the hazard and will act accordingly. Outrage management, that's, can't tell what color that is, pinkish. It's what happened last week. People are outraged because the assessment center is overwhelmed. So that is a concern. But at the end of the day, the goal is to reopen the school in a safe way. And we have provided this, or the system has provided this for 90% of the families. 90% of the families are well served in Gray and Bruce. 10% are not. And if you see the level of risk in that anxiety, is really not there. Nobody's dying. Yes, it is. A person is going to be affected. They cannot get to their work. Their kid is sitting in the car for a couple hours, and that's where we needed to provide that information to let the public know that this is the issue, and we are working on it. And hopefully, we would move that to the happy medium in the middle. If we can go to the next slide, please. So safe reopening is going to be modified normality. Nobody just can go to school like we used last year or the year before until we have that herd immunity, hopefully through a vaccine. And the messaging to the public is we need to all be patient with this. The school officials yesterday, I had a meeting with a few of them, and they report what they see in schools. All the things that I mentioned and, the anxiety, but they report that mostly 90% happy kids. There is an issue of high rate of absenteeism, 10%. And that's what I mentioned earlier in the presentation. We're exploring it. We don't know exactly why. Today, probably I would receive a report from the public health nurses to point out where this juncture is. It's not all these kids, 10% are sick. Some of them might have a runny nose, and we send those to the assessment centers, and there is going to be follow-up with them. At the end of the day, we have 0 cases in schools so far. We have no outbreaks. We have good data to say the schools has been safe. There was one incident, for example, that would speak against this last statement, not in a major way, which is there was one school with 55 kids absent on one day, and the test came back negative for COVID, all of them. However, that's good news for these families in the school. However, it's hard news to know that the transmission of another virus similar to COVID took place, and it took place very efficiently in that setting. So immediately our team looked into it, and the best of our assessment again at this point is these kids not specifically in this school per se, but in other schools as well, in other classes specifically, the kids are sitting face to face at one table. And the recommendation is each kid would be facing in the same direction. They don't face each other. The reason was the number of tables available for those classes has been low, and there has been an order. However, the supply in the market has been very slow, that these tables are not going to be in immediately. So we realized that the measures we put in schools work, and whenever these measures are not there, things might go sideways. We have the ability to detect it early, and if there is an outbreak, to stop it. So all in all, I'm cautiously optimistic that this is doable. It's not going to be the perfect 100% normal return, but it is manageable, and it should get better going forward. Again, I'm putting another equation. I'm putting factors in both sides of the equation. One of them would support safe reopening. The other one would caution what we might be facing. The colder weather has not arrived fully yet, and that might change the behavior of the public by definition, and the potential transmission of COVID in the community and in the school. So far, we have safe reopening, 0 cases. It's not practical for 10% of the parents and the community. We are doing our best with the partners to ensure those things will be mitigated. And next slide, please. And that brings us to the end of the presentation. Any question, Mr. Chair and Council?
Thank you, Dr. Harris. I will open it up for questions.
Yes, Mitch, I have a question.
Chris?
Dr. Ayer, last week we spoke of the stringent application of the testing by some of the school vice principals and teachers. Did you, I know you talked to the school boards about that. Did, in practice in the schools, did you notice any lessening of that stringent approach, and did it have a positive impact?
Definitely, yes. And you know, the report to be complete, the stringent application, it could be by many people, not just the school officials. That school officials are working with our nurses, so that could be mitigated. The parents are using the same tool, which used to be a list of symptoms, and people are looking at it. Currently, with the electronic measure, that's the main change, actually, to I'll take that decision, not put it on an individual who's not trained in clinical decisions, rather put it in the algorithm itself. But back to your question, the work with the school has been optimal. I had some concerns about different variables. None of them really existed. It's just better practice to explore all possibilities. Yes, the stringent application is not there, and if there is a gray area, public health nurses are supporting in making these decisions.
Okay, and then how many nurses do we have out in the field now? I know we topped it up with some of the funding we got. How many do we have out in the field working?
We have 9 nurses that were assigned for this program. However, their work is as a coordinator. They coordinate the other teams in the health unit, whether it's the COVID team or the vaccine team or the dental team. So there are way more than the 9 nurses to support the cause.
Okay, and then if I could just add one comment in terms of the outrage that some of the parents are feeling. I think one of the main reasons that there was so much anxiety is the burden of all this, the testing and the sickness. It does fall on working women, and they do experience a lot of real concerns about not being able to return to work, and it is a fact that it falls on working women, the burden of dealing with this problem.
Through you, Mr. Chair, I agree with that statement. And again, if it is under the control of public health, I would spare no effort immediately to correct it. However, assessment centers, as you know, are under the hospital control and Ontario Health. And testing could be done through other avenues, and we're trying to do all of them. Whether it's some primary care physicians, for example, in the peninsula, where there's no assessment center, have been contributing. Our team have been providing this through the swab team to individuals who cannot go to an assessment center, for example, the Mennonite community or shelters. We would deploy our team to actually do that testing there. The solution, I believe, has to happen through an assessment center, through potentially increasing the number of hours in the assessment center, increasing the number of assessment centers. For example, the average number of staff working in an assessment center is 3 staff, which is providing good service around 100 tests per day or 200. And it's not easy, it's not difficult to increase that number to 12 or 15 staff. There is, I realize there is pressure on the healthcare system. However, there is nothing more important than this. And if 3 staff can provide 100 or 200 tests per day, and we double them to 6 staff, that will take care of the issue immediately. And to that end, we are working. I meet with the CEOs of the hospital on a weekly basis. I meet with the physician leaders also on a weekly basis, and the team meets with them. And we hope solutions will be in place in timely fashion. However, again, I don't have control over the performance of these partners.
No, but it does look like the increased hours and adding the drugstores will be certainly very helpful. Did we get any of the drugstores in Bruce Gray added, or we're not a hot spot? So what happened there?
I'm not aware of any drugstore in Grey Bruce, and it seems the drugstores will be testing people without symptoms. And the reason is multiple fold. These facilities are not designed for infection protection or control IPAC. So if a person with symptoms walks in, they're actually introducing the virus, to whatever virus it is, to many people in that setting. And it is not a practical solution to take care of the testing that we need, people with symptoms or exposure. Assessment centers or primary care, probably the two major solutions, and each one of them requires certain work and resources to put in place.
Okay. All right. Well, thank you very much, Dr. Aaron. Thank you very much to our staff working on this most difficult issue.
Thank you.
Other questions?
Mitch, it's Al. Just like a comment from Dr. Era. I mean, I totally follow, through the media, your correspondence on, people that should be tested and not going to a center if you don't need to be tested. But it's almost as if it's a little contradictory when the Premier speaks, because he's saying, if you want to be tested, go to an assessment center and be tested. So from an outsider looking in, it looks a bit controversial that way. I just wanted to comment from you.
I agree. This asymptomatic testing took a life of its own over this past summer. And again, I don't have insight or direct insight into what happens at the higher level, but my own bias, the media outlets in big cities have really driven the public to believe this is a panacea, this is a silver bullet, and everybody has to. And the pressure on the system led to providing this as an option to everybody. As you know, I circulated that letter from the COMO, from the Council of Medical Officer of Health, advising the government this is not helpful in any way. There has been change in the narrative, and whenever there is a change in the narrative, it wouldn't be complete shift. Yesterday and today, the headlines, some of them would show that the message from the announcement from the province, the Premier himself, is moving to anybody who needs the test will get it, not wants it. So again, if you look at closely, there is some change in the messaging, and that's probably the way it should be. The announcement of pharmacies doing asymptomatic testing seems to be contradictory. But again, my own interpretation, Ian's interpretation here, if you're going to change the narrative, it might reduce the trust from the public into the establishment. So it has to be directed slowly. And that's why there is pharmacies to test asymptomatic, but we need to focus on testing people with symptoms in assessment centers. And at the end of the day, I truly don't think pharmacies will be a practical way to test anybody. The staff are not trained. The environment is not IPAC environment, is not infectious disease controlled environment. In all, I agree with you. There is contradiction there. However, hopefully there is some correction, gradual correction in the messaging and the narrative.
Thank you.
I have a question, Mr. Chair.
Yes, sir.
Dr. Era, in the last, well, I guess it was a week ago today, the Premier reduced the gathering numbers dramatically right across the province. A couple days after he had done the same to Toronto, Ottawa, and Peel, the hotspots in the province. What was the rationale for reducing those numbers in areas like Grey Bruce, where we've done so well and continue to do so well to keep the number of cases down? Because I mean, I've talked to a number of people who are very frustrated that we've done so well here, and yet it seems like we're being penalized because of the lack of care in the larger urban centers. Do you have any insight to that?
Certainly, I can provide the evidence behind it for the bigger centers and the rationale for Grey Bruce. If we are on our own as an island, I would not recommend it. However, because it's provincial, we cannot override it. So there's that practical aspect of it. It comes to the whole province, so we cannot override it. The evidence behind it comes from Ottawa, Peel, Toronto, where the recent surge in cases universally has been younger individuals, 40 and under, 20, 30 mainly, having private gathering, private parties, home party, backyard party. It hasn't been the restaurant, it hasn't been the other businesses, the grocery stores. So these controlled environments have been successful in preventing transmission. A private gathering, people getting together, having a drink and partying, has been the main driver of the recent outbreaks. So to that end, it would not make sense to restrict everything, rather this part. And like you rightly said, it was announced for Peel, Ontario, and Toronto. Then there was a discussion among MOHs, discussion with the government, and truly we do not need this here. Like you said, we have done really well that we don't need it. However, if we are not part of it, there are two things that might happen, and this is the rationale you're asking for. One, people who wanted to party in the neighboring health units would come here to have a bigger gathering. And it's not difficult. It's an hour travel instead of coming to Ian's place here or his brother in London. Everybody will come here. So the risk of transmission will be spilling from other places because we have more flexibility to allow for these parties. That's one, and it's not a major in any way. The second one, the major one, is the consistency in response. Whenever there is emergency and there is communication requirement, being part of the system would ensure that there is more response from the public to the recommendation, whether it's here or another health unit. So having to cross the province provides some reassurance or some consistency, some trust, increased trust in the system. All in all, these are the two main rationale. It wasn't my recommendation to go to it. That's like I started. It was a direction from the province based on the assessment from the center. If it was essential in any way, like school reopening, I would have advocated way against it. However, because it carries some benefit to us, carries benefit to many other areas, we see that it is not out of good practice to advocate for it or to interpret it more or less. Does that provide an answer to the question?
Well, it does. It does. Although I would argue, and you had mentioned that it creates better trust when it's a broader message. I would suggest that it maybe fosters some resentment because we have done so well here, and it's another. It was one person said to me, just another example of Toronto doing their own damn thing, and we're suffering because of it. But anyway, I understand your answer. I understand the rationale. So that's good. Thank you very much.
If I may add one more point, Mr. Chair, it's not very common, but it happened recently. The active cases we have, and other ones where there is one person would have a number of contacts. Early in the emergency, the number of contacts will be 3 or 4 people, maximum 10. That was the bubble. Currently, this individual had 35 contacts, just because there is potential for these parties. And this individual actually had parties in other health units or in other parts of the country. So again, having those restrictions in another place might prevent spill here and might reduce the number of contacts. Worth mentioning, the number of active cases is 3 or 4 at this point. One of them might be declared recovered today, but the number of contacts we're following up with is around 50. And most of these contacts came from one individual feeling that they can do whatever they want. And again, there is nothing it's going to be perfect decision, but all in all, it seems to be a reasonable decision for the province to go to that number.
Very good. I wasn't trying to suggest that we're all saints here in Grey Bruce. Mr. O'Leary is evidence of that. But in any case, thank you very much.
Thank you.
Other questions or comments for Dr. Era?
Mitch, could I ask a question of the group, of the board?
Sure.
On that note that Brian was bringing up, did anybody get any calls from people who are upset about having to change their outdoor wedding plans? I just wondered how widespread the impact of that decision by the Premier on Saturday morning might have been.
Personally,
I had a bride on my doorstep crying yesterday. I know that.
Yes, yeah. Yes, and I had one right away on Saturday also. Yes.
Personally, Chris, I've had none.
Okay.
Through you, Mr. Chair, we received most of these requests and questions. We received quite a few about weddings. The really good news for the group, for the individuals who are concerned about this, that ceremonies, whether it's church or organized wedding ceremony, is not affected in any way. Reception or the party part of it, if it is in a licensed hall or a licensed facility, there is no effect on it. It's only that party in the backyard or that party in a private house that will be affected. So most of the people who called us actually had a reasonable answer that they can live with. And again, it's not our role to make the decision in this case. Rather, we interpret the announcement from the ministry.
Okay, any other questions or comments? Okay, that's item 8182, healthcare modernization update. Dr. Era.
So thank you. The consult, as I mentioned last time, consult for modernization has been put on hold because of COVID. We did submit our part of the consultation early in March, meeting the deadline. That file didn't move. However, what moved is many organizations are communicating in a regional way. For example, as I mentioned, Ontario Health has been communicating with organizations in Grey Bruce as if we report to London or we receive direction from them, which is, as I mentioned, concerning. The board last time asked us for a list of advocacy avenues to ensure that if there is any regionalization, it should follow the appropriate channels of consultation and the outcome of the consultation. So I can provide a list of venues that we believe could be of value in this case, and I would appreciate direction from the board to which one we need to focus on. And all in all, we are planning to contract communication firm in general to optimize our strategy for communication in public health, and to, as one item, is to see what we can do with advocacy with these potential venues. And the list that I'm looking at, probably topping that list, is the Network Agreement Planning Subcommittee, NAPS. It used to be a very effective meeting. It has not happened in the past year and a half, probably COVID mainly the reason. I do believe it's worth calling for that committee to meet and many of you would be involved in it directly or indirectly. The other avenue would be the Western Ontario Wardens Caucus. This is the same exact group that would be affected by regionalization, because it is the counties, the rural areas, it is the counties that are not major centers like London or the bigger cities. So those are the people, probably a presentation from myself or a communication from the wardens to that group could bring some awareness and more information to the committee and advocacy to see if they can support. AMO is, again, a major player, has always been in supporting the connection between public health and municipalities, not public health reporting to a center in a region or the province. So my recommendation would to go to the NABS first, to go to the Western Ontario Wardens Caucus, then take it to AMO after the Wardens meeting would bring that more awareness to the issue. So when it goes to AMO, it will be a mature advocacy approach. Locally, we can look at many things, whether it's physician leaders, local MPPs, provincially, we can communicate with the Ministry of Finance, the Treasury, and in public health, there are different partners, whether it's COMO or Alpha, by definition, will be involved through this advocacy. So this is the list of things initial list, and it could be optimized with your direction and involvement of communication strategy to support it.
Thank you, Dr. Ayer. Any suggestions, folks, or comments?
I just had a question. So the Ontario Health is active again. And so this whole initiative with amalgamation of health units is now active again. And we just need to start preparing for when it becomes active. And you have very good suggestions on ways to advocate for our health unit and its unique advantages and how far we've come. And, you know, as you've mentioned, all the things before, Indigenous relations, rural area, give credit to the health unit staff for all their work in different areas, including COVID. So how immediate is this need? Do we need to start now again, ramping this up?
So the formal process of consultation and amalgamation of health units has been put on pause, and there is no immediate need there. The immediate need would be to bring awareness that there has been movement in different parts of the system to a regional structure, not specifically amalgamation of health units, but it is actually leading to that. So again, the advocacy would not be to talk about amalgamation of health units or not. It would be about the necessity to focus on local need, not on regional need in the middle of emergency. If I may provide a concrete example, long-term care is a main partner in this emergency because they take care of the vulnerable population, the older adults. And historically, and we always communicated with them one-on-one directly. We get the report immediately. In the middle of emergency, there are people from the hospital sector coming to that table. Then there are people from London, Ontario Health, coming to this table, and they're coming with the notion that they're directing long-term care in Grey Bruce to communicate with them in the middle of emergency instead of communicating with us. So specifically in this example, we sent an invitation to all long-term care director of care, the people who the officials who lead these organizations to come to the health unit in person. We had a session with them 2 days ago. It was a great success to bring this awareness that legally, the legal framework in Ontario currently puts the mandate of managing these outbreaks in the facilities, in long-term care facility, in the hand of the Board of Health, no other party. So when we brought this legal presentation to them, our legal presented, we provided them with, different examples where things went off the rail when a long-term care communicated with the hospital instead of us, or communicated with London instead of us. There is that awareness just was immediate that the clarity of role was necessary. It was that wake-up call that, okay, this is what's going on. We don't need to report to London. We don't need to communicate. And frankly, in general, in any situation, if London can provide better direction for Gray and Bruce, how come they have death, we don't? As simple as that. But back to your question, Mayor, it is not the amalgamation of public health through the ministry that we are advocating for that can wait. It's rather the awareness that different partners are taking roles that don't belong to them in the middle of emergency.
Okay. Thank you.
So Dr. Eyre, would you like some direction today? And the list that you gave us is very extensive, but on the other hand, does it not hurt sending a letter to all of those organizations? And I'm just putting that out there for the board and their thoughts.
If the question to me, I do believe that would be a great start, and it might really take 70% of the heavy lifting to communicate the information to them if they receive it formally from the board.
Yeah, I agree. I think that's the way to go. So do I have someone that would like to move and second? Basically, it's an awareness campaign more than anything at this time, and to bring to attention to these organizations our thoughts to see if there's any kind of support out there and with the different organizations. Brian?
I'll move it.
And
I'll second it.
Seconded by Brian. Millen, any further discussions? Hearing none, I will take that as accepted and carried. Thank you. Do I have a mover and seconder for Dr. Eyre's update on the school reopening? I know it's more for information than anything, but I think it's important that we recognize that through a motion.
It's O'Leary.
O'Leary and Buck.
Buck will second.
Thank you. Any further discussions? Hearing none, I will consider that carried. Thank you. Corporate services.
Sorry, Mr. Chair, it's Erin.
Hi, Erin.
Before we move on, could we just quickly go back and do one procedural motion to receive the correspondence and media?
We can do that. Thank you for keeping me on my toes. I missed that.
So moved, it's Patterson.
Thank you. Seconded.
Edie.
Thanks, Ann. Any further discussions? Any objections? Hearing none, I will consider that carried. Thank you. Okay, now corporate services. Matt.
Thank you, Mr. Chairman. Actually, on the first two memos, I have Christy, who is the primary author. So I'll let her drive that part forward, and then I'll take the last memo.
Okay, thank you. Welcome, Christy.
Thank you, Mr. Chair. The financial report was provided for your review, with the main theme being that COVID response is consuming a lot of our resources. Specifically, I would like to point the attention of the board to the section that summarizes the expenses incurred and projected to the end of 2020 that we provided for information. And are there any questions on the first report?
Any questions for the board? Do I have a mover and seconder to receive the financial report for July the 20th or July 2020, sorry?
O'Leary.
O'Leary. Seconder.
Milne.
Thank you. Anyone opposed to accepting the financial report? Hearing none, I will consider that carried. 9.2, the 2020 funding announcement.
Perfect. So we did finally receive our 2020 funding announcement. The primary two things to note on that is that the ministry is providing mitigation funding for the counties for 2020 and 2021, and that instead of our mandatory program funding being split by program, it's now mostly lumped into one lump sum.
Okay, thank you, Christy. Any questions? Do I have a mover and seconder to accept that report?
Edie,
Edie,
O'Leary,
O'Leary. Anyone opposed? I will consider that one carried as well. Thank you. Thank you, Christy.
Thank you.
Matt? Is Matthew on mute?
I'll start that again. Sorry for the, you're watching my lips move, but no sound coming out. Our telephone upgrade is scheduled to happen actually on October 3rd. We are progressing rapidly and I think nicely. So we should have our new system up and running, but we've identified a couple of other gaps as the technology and its abilities became more well known and understood, as well as some changes that have happened out in our communities. So that the daycare situation, long-term care, and the school programs that we are out there supporting are also looking at utilizing this technology to properly maintain communications. That requires more licenses. It's not a functionality addition, it's actually broadening out that functionality so we have actually more users taking advantage of it. That unfortunately has some costs associated, and that's what I've presented today. I'm looking for.
Matthew, any questions or comments?
I have a question, Mr. Chair.
Yes, Brian?
I note, Matt, that in the previously approved motion for, or at least in your report, the amount approved earlier provided an additional 15% for contingencies, yet this go around, you're only asking for a 5% contingency. Why the variance there?
I think we're, as time and experience with the new technology is showing us, I think we're identifying much more of those contingencies. So I'm not expecting that we're going to have much more contingency to deal with. The 5% is very low. And for that reason, because we have gone through quite an extensive process to identify gaps.
Very well, thank you.
Other questions? Do I have a mover and seconder to give direction for the additional costs?
So moved, it's Patterson.
Thank you, Sue. Seconder?
Buck, I can second.
Thanks, Buck. Any further discussions? Hearing none, I will consider that carried as well. Thank you very much. Okay, moving on to other. Brian O'Leary, did you want to start?
Sure, I'd be happy to start. I just want to, I'll begin by just taking a line out of the Municipal Drug Strategy Coordinator's letter, asking the province to immediately fund and scale up implementation of safer supply initiatives to save lives and improve the health, safety, and well-being of people who use drugs in our province. And the reason I really didn't want to talk about it when Ian's presentation, or to lock it in with Ian's presentation, is because I didn't want to take anything away from it, because it was such a good presentation. But I want to talk about the other side of this. And some of the people around the table have already heard this. We have a hotspot in Owen Sound, or what we've identified as a hotspot. which is a drug house that we've been dealing with the entire summer. And there's a group of neighbors that we've met with mental health and addictions and city council and that sort of thing. And anyways, this neighborhood, they send out a 3-page letter, and I'm not going to read the 3-page letter, but I have highlighted some of the things that they've said in the letter, and I want to share it with the board. We are tired of having to be hypervigilant and on alert at all times. We have to lock our doors even if we go inside for a minute in order to feel safe. Our neighborhood consists of mothers, fathers, children, and grandparents. We have a mixed neighborhood where we have young children, working families, and retirees. We have people who are in trades, healthcare workers, educators, people who work or have worked in social services, and many other professions. We're all taxpayers, and many of us have lived in the community for a long time, and we deserve more. We are fearful in our homes when drugged out people try to get into our locked houses. Walk by checking out our homes and backyards, and with people running through our yards to escape police. We are tired of having to contact police for assistance due to violence or escalating tensions arising from one location. Occasionally, the police officers are present as many as 5 times in a day to deal with issues at this one house. We are traumatized when a resident of that house was an overdose fatality. We are worried about the safety of our children walking to school at Hillcrest and OSDSS. They should be able to go up the catwalk at 8th Street and feel safe. Their parents and grandparents should also feel safe with them going to school. We don't accept people trespassing on our properties. All of these issues are currently being caused by the people living and visiting or doing business with people at one house on our street. As a recently retired person and a resident, I certainly know that I have had enough. There are constant noise infractions, yelling, screaming, calling for help. We often have to have what seem to be sketchy people, drugged out people wandering in front of our houses, looking at our homes and walking up our driveways. I, for example, had a person try to break into my house forcefully while my grandchild was present. I am so distracted when on my front porch that I check out each car and person going down my street in an effort to feel protected. Others feel the same, and some have spent a lot of money on security cameras. Unfortunately, the more we see, hear, the more anxious and unsettled we feel. So those are some of the things that they've mentioned, and we as a city, we already have one of the highest police budgets in Ontario, and we just don't. Our police don't have the resources to cover this. So we've got, in each shift with our police, we have 4 officers. One of them is a sergeant. So we've had to hire a security company to have, whenever the police can't sit in front of this house from 11 at night till 6 in the morning, we have a security vehicle, and paying for that security company to sit in front of this house from 11 at night till 6 in the morning, because these people are scared to death and can't go to sleep at night unless they know somebody is out front watching over them. And I guess what it comes down to is the neighbors have a blog now. They're almost like one big family. They talk with each other, and now they've come to me and said, listen, you sit on the board of public health. Can you just share our story? So I don't know if there's any direction that could come, but you see, and this is what they see. We're doing so much, or trying to do so much for the people that are addicted to drugs in our opioid situation. We're lobbying the government for money, and these people are saying, what are you doing for us? And I suppose it's a fair question. It's we can't just blame police. It's something has to change in what we're doing, and if we're going to look out for one, I think we have to look out for the other. I know there's one, the one thing I should mention too is one of these ladies is raising her 8-year-old grandson because her own son is an addict. So she is well aware of the opioid situation. She's been through it. She's lived through it, and this is what she's going through now. And so I don't know if Dr. Eyre, you want to comment on this situation? Maybe give me some kind of direction. Like, what do I tell this neighborhood?
Through you, Mr. Chair. This is a very complex subject, and complex issues and problems don't have simple solutions. They do have simple solutions that they don't work. Having the harm reduction approach recently in the past 10 years really is not going to achieve the drug-free world. I do believe in a drug-free world. Like people should not need drugs to be happy or to forget or to remember. And I am not utopic in my thought. I know it's not here. It's not to happen. It's going to happen next year or 2 years from now or 10 years from now. But there is no reason why this would be a problem that our society will carry on with. I am afraid I don't have a simple answer for the request. What the family articulated is directly related to mental health. Many people can just brush it off on the side and say, this is safety. They're talking safety, they're talking enforcement, they're talking police. I do believe it is related to their mental health. If a person is not safe in their home, that's one of the cornerstones of human right. Like nobody can do anything with their life if they don't have the safety in their own home. And this is the issue in this case. And again, what we can do to these families, I don't, like if I try to take a stab at answering this, I would fail dramatically if it's less than a group of experts who are putting together a robust or useful framework to tackle this issue. I can mention many things that we can do to the community, and we can tailor it to this sub-community. However, it's not going to address the issue. There are legal aspects to it. There are social aspects. There are technical aspects. There are ethical aspects, and to tackle these things just with a simple answer, again, I would fall short in answering it. It's worth rallying people around the table, the same working group to support opioid emergency. It will be the same partners to start being aware of this aspect of it, and maybe to have solution that will provide measures that provide some solutions for both. You rightly identified we're doing something for one, not the other. That could be a place to start, and I'll be more than willing to take it as a direction for the coming 5 years in our strategic plan as a task, part of that strategy.
Right, and I appreciate that. I guess I'm not really looking for a direct answer today, but I think sharing this with everyone, just maybe there'll be a phone call down the road or an email that's going to send me in the right direction. But it's I've spent a lot of time with these people. I've sat on their front porch from 10 till midnight on 3 different occasions, just to see for myself. It's real, it's crazy, and it's sad that people have to live under these circumstances. But I guess the only other comment I want to make is, we talk a lot about the partnerships we have with addictions and mental health. And, there was one lady that sat in this neighborhood meeting. I can't remember. I think it was alcohol addictions and something like that. She was handing out her card to these neighbors and said, if you ever want to call me, I'd be happy to reach out and talk to you. And one of these neighbors called this person on September 4th, and the call hasn't been returned yet. So, one of the questions that they're asking me is, what are some of these partnerships that we talk about? Are they real? Do we really have partnerships? And that sort of thing. So I'll just leave it at that. I don't want to have a long discussion about it. I just want to throw that out there and let people know. And hopefully I'll be able to, go in the right direction moving forward. Thanks for the time.
Mr. Chair, through you, I would suggest, and I will bring it back to the board, that the same working group that we're leading for tackling the emergency of opioid or the crisis, the opioid crisis, to bring to that group the awareness of this issue and to have the insight that any solution and support to the people struggling with opioid should have consideration to the people around them in the neighborhood, not their just immediate family, rather the families itself. I'll bring back an update how far we proceed with this. It's not going to be in 1 month or two. Rather, these changes will take at least a year to have that group aware and involved in implementing solutions. I'll update the board quarterly or more frequent if the board wishes.
Great, thank you.
Would you like direction then from the board on that, or are you just going to take that as a to-do list thing?
It could be done either or, Mr. Chair. It will carry more weight if it comes from the board. However, I don't know if you want to have it as an item for discussion, because it came as a notice from one member, and I can act on that, and I will act as vigorously as if it came from the board. But
yeah, I think because it was an information item brought forward today, that if you bring it back as an item at the next meeting, then we can deal with it then and give direction, I think, in all fairness.
Certainly, I'll bring it back to the next agenda.
And I know, Brian, this is something that is going on in all of our communities, and it's tough, and I sympathize with those neighbors. I truly do, and it is a difficult situation. I think we had the solution, the easy solution, we'd all be doing it, and that's the problem. So I do sympathize for you and your community, but I also know what's going on in a lot of other communities. So it's a tough one. Okay, Dr. Era.
The next item is the special mitigation measures for special events, Halloween coming soon, and down the road to Christmas. So there has been announcement or communication from the ministry that there will be provincial mitigation measures provided. We have not received communication on this yet, or the final guidance or communication tools to use. To being proactive, we developed a couple of these tools just to raise awareness and to ensure people may benefit from having specifics about the event itself. In general, there is optimal compliance from the public in Grey Bruce to the recommendation from public health against COVID, or to tackle COVID, and those are the same recommendation for these events. There will definitely be benefit if we add a bit more specifics, and we have developed again two communication tools circulated on our social media. They were approved early in the week. I don't know if they went out already or not. I'm looking at.
They're starting to be into circulation, yes.
Drew mentioned they're starting to be in circulation. If the province didn't deliver, and I suspect they will, they have announced it, we are ready to put things together in short period of time before the event, and to ensure enough information provided to the public. Again, I'm repeating the same circle. The advice to protect oneself and their family and the community is really the same. So I am concerned, of course, about these events. However, I do believe we can have these events in a safe way in Grey Bruce, based on the epidemiology and the compliance from the public that we have.
Thanks. And I think it's very timely too, because I actually spoke to a young couple the other day that plan on still getting some costumes for their little people on Halloween night, but just going to visit maybe grandma and grandpa and a couple close friends that they're in their circle, that they're not going to go physically door to door. So that's just one example. And I think the parents are taking that that approach, at least in the people I've been speaking to. So hopefully, and then obviously with Thanksgiving coming up and then Christmas after. So hopefully our people are wise in their decisions on all those evenings or those special times. So, okay, so that is for information. Any other comments?
Just one, Mr. Chair, if I could, real briefly, in regards to my earlier comments about maybe the perception that there's frustrations in the community, I just wanted to make sure that Dr. Era understands that for the most part, and in fact, most of the people I talk to are very appreciative and thankful and supportive of all his efforts to keep us safe. And I just wanted to make sure that that message was conveyed, at least from me. So thank you, Dr. Era.
Thank you. I'm honored. Thank you.
Okay, if there are no other comments, we will move into in camera for 2 items, advice subject to solicitor client. Okay, so on the first 2 items, the board received that information from staff, and on the second enclosed or in camera meeting agenda item, we have given staff direction. There are no other. Oh, I'm echoing there. Okay, so at this point, we need a mover and seconder to adjourn this meeting.
O'Leary.
O'Leary.
They do the motion that they needed to do.
Edie.
Edie. Okay, if there's nothing further, thank you everyone and have a nice weekend and stay safe.
All right.
Thank you. Thank you. Bye, everyone.